So our next speaker here is Emily Lonsdale. She's a research project manager at BC Cancer, and she is with us today to discuss embedding community voices into an equity-oriented model of cancer care. So the floor is yours, and you have 15 minutes for your presentation, and then potentially 14 minutes for a Q&A. Thank you
Okay.
for
Thank you,
being here with us.
Marcelo. Thank you, everyone, for being here today. Just checking my audio is okay, loud and clear for you. You can hear me?
Yes.
Awesome. Okay, I'm at the conference center, but just had a couple connection issues earlier. So thank you so much, everyone, for being with me today. I'm just going to share my screen so you can see my presentation here. So as mentioned, my name is Emily Lonsdale. I use she, her pronouns, and I work as a research project manager at the BC Cancer Nursing Research Department. We are newly situated in the BC Cancer Research Institute, but previously working on a provincial team under the operations portfolio. I would like to name first and foremost that I am just one voice representing a whole collective of brilliant individuals who are very passionate about bringing an equity lens to cancer care. And I'm very grateful to be speaking with all of you today. The work that I'll be talking about is situated on the unceded, ancestral, and stolen territories of the Musqueam, Squamish, and Tsleil-Waututh nations, who have nurtured and cared for these lands since time immemorial. And I think it's really important that I begin kind of with a statement of humility that I am presenting to you, but I am frankly a learner in this space. So approaching the agenda with an essence towards lessons learned, but really the fact that this is a constant journey around patient engagement, and the Coast Salish teaching of team a bit, which means do your best, is something that grounds me in the work that I do and in the team that I collaborate with. Because I think if we think we've done it right, we probably need to start again. It's going to be a constant learning process. So hoping to embed a couple of lessons learned in our project and share a bit about what the impacts of SPOR and wider Michael Smith has been within the team that I work in. So a bit of a 1,000-foot view on the project that I manage. We lovingly refer to it as EMOC, the Equity-Oriented Model of Cancer Care. It's a quality improvement initiative funded by the Canadian Partnership Against Cancer, and it's a multi-year, multi-phase initiative aimed at really at a simple level, tailoring the new kind of team-based care model that's being implemented across BC Cancer's regional centers to embed an equity lens in the work. And when we're talking about equity in our work, we're borrowing from the EQUIP healthcare programs lens on equity, which really centers these three key pillars. We're talking about trauma and violence-informed care, harm reduction, substance use health, and culturally safe and anti-racist care. So weaving in these lenses into the day-to-day work of an interdisciplinary team that's supposed to wrap around people and meet them where they are, where the patient and their families and the people who support them most closely are at the center of care, but a whole group of people is surrounding them. And we're piloting this project specifically in Vancouver because a large number of our team is situated here. The operational context was really keen to accept this sort of pilot project to embed an equity lens. And we know that in Vancouver specifically, and I appreciate kind of the duality of my colleagues or fellow presenters who are talking about the North. We know that in Vancouver, certain populations, such as folks who face housing insecurity, people who use substances, people who face multiple complex barriers to care, or people who have experienced trauma and violence at the hands of institutions such as health and research, are populations of interest and folks who are really deeply impacted by inequities across the healthcare system. However, what's cool about this model and the thing that we're thinking about from the whole get-go is the ways in which these different patterns aren't just a Vancouver problem. These are problems widely experienced across our healthcare system. Substance use is not explicitly a urban issue in Canada, and housing insecurity is not explicitly an urban issue. But the ingredients of how we're approaching this project and the ways that we're looking at the processes of implementation, evaluation, and sustainment are with a lens towards spread and scale across the province. So when we got started in the work, anything that is an equity-oriented intervention needs to account for the fact that, how prepared are you to actually take on this kind of work? And, who are you in the spaces that you work in and the teams that you occupy to take on this work? And I think within our own team, we had to do considerable reflection and kind of purpose setting before even embarking on assembling the team and inviting folks with lived experience and patients and partners and community members into the room to ensure that we had capacity for meaningful engagement. And I know those words kind of get thrown out in the landscape, but meaningful to whom? The question we had to ask ourselves is obviously meaningful to the folks who are faced by these health and social inequities in our system, the people who have the lived expertise to be able to share with us and impart that wisdom. So we had to look kind of internally first. And I think from a foundations perspective, there were a number of kind of critical steps that our team considered when it came to setting the infrastructure or foundations for meaningful engagement. So as mentioned, at the beginning, thinking about the reflection, question the purpose and outcomes of our work, collaborating beyond disciplines and departments. So something around the kind of the equity orientation in cancer care is imagining the ways in which teams could be stepping outside their silos and coming together to really advance these complex system level solutions, because we're not just thinking at the, patient to provider interactions. We're looking at this from a structural level of how can we actually enact equity across this health system. We're also thinking about kind of building that internal capacity and bringing the expertise into the room. So we invited different folks from academia, research, people with lived experience, partners from the patient and family experience team at BC Cancer. We're very fortunate that there is kind of dedicated resources within the organization to embed patient voice into initiatives. However, the way that it's been incorporated into research at BC Cancer has not always been like a clear path, and oftentimes patient initiatives are kind of at the regional level really focused on like experience committees and things like that. So we had to think about building capacity for research that actually embedded patient and community voice in a good way. Beyond that, and I think coinciding with inviting that expertise and collaboration into the room, thinking about the structural considerations. So, but the means for payment, even something as simple as making sure that folks get paid on time in a way that makes sense for them and meets them where they're at, isn't necessarily the easiest thing to do when there is a lot of kind of structural limitations for allowing speedy and effective payment mechanisms. And that's been honestly an ongoing kind of consideration for us in the work, and where we actually had to create new workflows around e-transfers or being pilots in taxi vouchers and just all of these kind of like small things that make a big difference in actually enabling the infrastructure for folks to engage across different stages of the project work. When we invited lived experience advisors to the team, we also had to take an atypical approach to recruitment, which meant leveraging kind of relational networks, going through partner organizations in PHSA to invite kind of different lived experience to the table, because within certain kind of patient networks across BC Cancer, there's not always folks who bring kind of an equity lens to the table. Oftentimes, our recruitment networks might be of a certain demographic, and it required us to be creative and intentional about how we went about recruiting and inviting people into the work. And then again, health systems move at a pace that is often, a million miles a minute, but taking the time once folks were invited onto the team to actually build relationships, safety, and trust, because we knew that, you can't just go bolstering ahead without taking the time to connect before content. So that's been a very kind of intentional part of our structural foundations. And then we went into kind of more of the actual project activities itself. We spent about a year doing planning activities and co-designing this model of care that we're now implementing. And also along the way, because I'm situated within a research department that's passionate about actually translating these mechanisms into, outside of the shelf and onto the bedside, the outputs and knowledge mobilization along the way and being able to identify kind of which pieces of the journey we can share with others has been a really key part of kind of that structural foundations for the work that we do. So getting into a bit more of the actual collaboration and action itself, during the year of planning work that we did with community and with our brilliant lived experience advisors on the project team, we were able to invite perspective on which parts of the cancer care journey could actually be tailored to better meet folks where they're at in a person-centered way. because of the patient populations that we're interested in, this looked like us kind of co-developing new clinical training and tools that actually situated kind of clinically relevant and person-centered approaches to having conversations about social determinants of health in a good way, to identifying kind of barriers to accessing equitable care and outcomes, and then to making linkages to the various folks that are most important to connecting individuals in community. So one example of the work that we've done that kind of is being implemented as a result of patient and community voice is these 3 decision support trees that are supposed to be helping interdisciplinary care teams work through kind of addressing potential social determinant needs that come up as a result of having a good equity-oriented conversation at intake. This equity-oriented intake conversation is truly centered around patient voice and people with lived experience, in that we're giving training to teams on the front lines about the ways in which folks receive our intakes at BC Cancer. So there's a lot of questions that we ask people, and we recognized within the kind of clinical intake convo, we do ask questions about social determinants of health, but we don't necessarily frame them to staff as like the why behind why we ask some of these questions, why it's important to talk about these things. And then from the patient perspective, we don't always share the why either, why it's important to know about things like substance use health, or when we're asking folks off the outset, there's a question in our intake around, what do you want your care team to know about you? And a lot of folks didn't even know that this was kind of buried in our EMR, but we're wanting to kind of uplift those components of our intake that do such an important job of identifying what things really matter to people, especially folks who maybe have a harder time successfully moving through a cancer care trajectory. So bringing kind of a different lens, it's really a cultural shift for us. It's taking the time to kind of slowly build that capacity with staff and clinicians, that they understand why we need to have these conversations, why it's important to have them. And many of folks do recognize that. Like, I want to affirm the fact that for many people, this is work that they are already doing, but we don't necessarily have that formal structure of training around this is how to build capacity for you to ask it in a good way. And then once you're identifying those kind of social determinant barriers that are creating inequities in the cancer care journey, these are some potential tools that are going to help you respond. So those repositories on the last slide are intended to be, okay, so you've identified a need. Now, here are some ways you can navigate through supporting that person in connecting them to the right services or the right supports that are going to meet them where they're at, if someone's interested in pursuing that. So thinking kind of more widely about the impacts of SPOR in our department in nursing research and in EMOC specifically, the parallel kind of metaphors are happening here, but I really think of Michael Smith and SPOR as a bit of a bridge and a builder within our department. So specifically, 5 or so years ago, when my boss, Dr. Leah Lambert, began her work of nursing research at BC Cancer at the provincial level, it was a Michael Smith-funded collaborating and convening and collaborating C2 grant that actually allowed us to kind of survey the landscape of what cancer-related inequities looked like in BC, what the conversations and direction heading, what priorities needed to happen in order for us to advance equity-oriented cancer care. And then building out of that has been just a brilliant kind of network and almost a garden of an equity-oriented research program at BC Cancer led by nurses that over the past 4 years since I've been on this team has built the capacity for us to invite different folks to the table who are not always at the table, and to advance different projects that are furthering a research agenda that actually documents what kind of impacts this work can have within the system. So whether that's through research, QI, knowledge mobilization, and just the uplifting of different voices, whether from an interdisciplinary perspective or from a community perspective, to be able to share and translate these really promising approaches to just meeting folks where they're at and bringing different voices to the table. And I think that's been the greatest impact that SPOR has had in our work, and whether that's been through funding projects that my PI has been leading, or just offering the connection to continued resources different approaches, different people who are also experts in this work, other learners in this work. And I think that's such an incredible value add, because this community of practice and the momentum that can be experienced when we're disseminating kind of these ideas and approaches is really something to just be in awe of, frankly, at times. And I'm very grateful to be a part of that community of learners and doers who are trying these things and pushing the status quo, because I really do think it's a substantive shift in culture. So with that in mind, if anyone is interested in hearing more about the work that we're doing, the ways that we're thinking about kind of spreading in scale to additional regions, if you're situated outside of the Lower Mainland, if you're interested in embedding kind of a different approach to capacity building and equity-oriented work in your organization, we have a strong list of resources to share, and we are in the process of authoring and co-authoring a publication with our lived experience advisors around some of these lessons learned, and we're looking forward to sharing that eventually. So thank you so much, and wanting to open the door for any questions.
Excellent. Thank you very much, Emily, for this fascinating project, as well as learnings from your experience embedding patient voices into your work. Great. So we have some time for a Q&A for Emily. Yes, and I see a hand up. Jude, would you like to start with?
Sure, a great presentation, Emily. I really enjoyed it. Thank you so much. And I noticed on one of your last slides where you were talking about, in one of the frameworks, you talked about inequities in the area of health and social inequities in housing. And I'm assuming that means like just having stable housing in one of the most outrageously expensive cities ever. And I just want to share an overlap in that we have a huge initiative called Housing as Healthcare. But it's from a slightly different lens. It's for rural people that have to come from far-flung communities to receive treatment in Vancouver. And I'm focusing specifically on solid organ transplants. And what I've been saying for a while is, heaven forbid anybody needs an urgent solid organ transplant during the FIFA World Cup, because it's going to be completely unattainable. So I'm wondering, like, I know I'm looking at it from a slightly different lens, but it feels like such a monolith, like it's this huge thing. How do we address that? Because Ministry of Health has said, no, that's not our issue. That's housing and development. And the Ministry of Housing is saying, yeah, no, we're not worried about that. So how have you navigated that? It's so important.
Yeah, no, thank you for raising this, Jude. I think that it is a critical need. Obviously, the housing is healthcare, or the Housing First program and initiative that has been rolled out in the past. I was involved in an evaluation of that, actually. I think that from our perspective, like, obviously we know within the scope of BC Cancer, our influence isn't going to be in BC housing. However, we have gotten to the point where these partnerships between primary care community, the community health centers, downtown east side, working with VCH, different kind of partners, many people are at the table. And I think at the end of this project, something that we will have is a evidence-informed recommendation towards the role that housing plays in offering kind of stability for a number of populations when they're coming for care at BC Cancer. Simultaneously, our Indigenous patient navigators, we have IPNs at each of the regional centers, and I know the two IPNs at Vancouver Centre, a large amount of the work that they do is actually around securing housing for Indigenous patients that are coming to receive care at the Vancouver Centre during that time. And the only reason they can do that is because, the funding that is available through their operational department situating and working in the time that they have dedicated to partner with nations that also have grants or things. Like, everyone is just scrapping over trying to figure this out. So I guess I would say, from a housing perspective, I know our project doesn't have a solution. However, what we are getting together is a very powerful collaborative voice. And I believe that it's that kind of advocacy at the end of this work that also resembles the so what of it, really. Because if you're not documenting those problems, if you're not, yelling from the rooftop that this is a very real problem for people, then the stakeholders and the partners that need to get to the table to work together aren't going to be there. So I think advocacy is a key part of kind of carrying out some of these lessons. And our lived experience advisors have very much so been like, you need to keep on talking about this. Like it's not just writing about it in a journal. It's also talking to someone who has some levers of change at their avail.
Excellent, and also bringing up these topics to these forums, right? Is the right place to continue this conversation. There are two questions, Emily, in the chat. Number one, do you have any suggestions for reaching equity-deserving groups who are typically not represented in research or might not be as involved with partner organizations? What are your suggestions for reaching these underrepresented groups in research?
Thank you. So yeah, I think that, as someone had already said, the voices who are often the most needed are often the ones that are not invited into the room or at the table. Something that we've learned in our kind of recruitment process has been that, like, oftentimes, so in community, if you're an outreach worker pounding the street on the downtown east side, relationships are everything, and you have to build them, and you have to start slow and accept that. We had a year of relationship building project funds through the Canadian Cancer Society that allowed us to continue to show up in community, bring food, get to know people, listen to what was important to them, and essentially demonstrate our commitment to being partners in the circle of care. And I don't really think there's any sidestepping the necessity of those relational building blocks. Sometimes a really good hire goes a long way. Not to pat myself on the back, but I came from community services prior to working in the health authority. So I already had an existing network of folks in community that I was bringing in my toolkit. And similarly, my colleague Sophie Banner-Martin, who worked for the Patient Family Experience team, she had a past life working in mental health and substance use. So she brought that Rolodex, and then essentially we were doling it out, thinking like, okay, who can we talk to that is doing really good work of inviting very underrepresented voices to the table, or can share some of those promising practices with us. And that's how we got started. So build in budget for food, take your time, and come back again and again and again. And not just with the essence of, we want to invite you to come and work with us. What are you also bringing to those spaces? What are you offering when you go? So we listened to the advice of our colleagues at DCHC around what they're looking for, what their folks had questions about when it came to cancer. And we had a couple nurses go down to the center and spend some time doing just drop-in conversations and training with folks, because that was something that they were interested in. So it had nothing to do with the project outcomes, but it was everything to building trust and enabling folks to feel comfortable coming and working with us.
Excellent. So we hear again relationships, trust, and allowing ourselves times to be able to invite these groups. There's a second question which I love, which is in the realm of knowledge translation. So the question is, what do you find are some of the hardest challenges with knowledge mobilization in your work, and how do you address them?
Yeah. This might be like a biased answer, so I will say this is my response, but not the response of my team. I think we have to be very critical about what we, the Royal Academy of Academic Research, privilege as knowledge to share and uplift. I think many times within both research capacities and healthcare capacities with a biomedical model, we are kind of stating like, well, this isn't really pragmatic enough advice. This is too conceptual. This is my colleague and I had a conversation last week whether giving people advice on being friendly was impactful enough kind of approaches to be mobilizing. But I think there's this inherent tension with relational work, with equity-oriented work, of the advice. Like we're noticing this even in our process of co-authoring a paper with our lived experience advisors, that the model for mobilizing and sharing knowledge is an inherently kind of biased one, as far as, being taken seriously enough. Is this rigorous enough? And something like taking time and going slow is advice. It's anecdotal, but it's also informed by the lived expertise of people who do this work really well and are seeing very real world impacts. So I guess equity-oriented research is a hard one to mobilize because the evidence isn't always the square peg round hole situation that journals are looking for, that decision makers are looking for. And so I think that it really requires a multi-method approach. Qualitative stories are so impactful and so important, but also when and if possible, using the infrastructure and the partnerships that you build within your spaces to uplift different types of information that are going to position these points in a good way to advance change. So I guess it's straddling all of those worlds at once, holding all of those tensions to be true, and still going for it. Like I'm very curious to see how our attempts at publishing go, given the tensions we're even experiencing within our own team during the writing process about the way of framing these stories, the way of framing these lessons, and how we hope other teams take it up. But they're very real lessons learned, and our partners be very important if other teams want to work with people with lived experience the way that we wanted to.
Excellent. Thank you for this quite thorough explanation. And I think you're intersecting the equity lenses into forms of KT, particularly allowing different channels and mediums depending on the populations. This is excellent. We have time for maybe one more question, and there's just celebrations. Maybe I'll take the opportunity to ask you. You referred, Emily, to capacity development and some of the new practices that your project or the projects have tried to develop in cancer care. How do you know and when the practice is sustained directly in the care? So it sounds exciting. It's a project. It's bounded in time, etc. How do you observe that aspect of from allowing to capacity building to sustainability? What are some of the indicators that you can say we have built capacity building, or now it's already embedded within the practice? I don't know if you have some ideas about this.
No, that's a really good question, Marcelo. And I think that again, I'm really grateful to our funders at the Canadian Partnership Against Cancer, because this is a very unique funding opportunity that I would say deviates a lot from a typical kind of tri-council, you get it, forget it, like you're on your own kid approach. So I feel very handheld in many ways as a novice project manager enacting this work, because we had to submit like a proposal template that essentially outlined what some of our goals were for evaluation, for sustainment. And it was from the very get-go of these ideas being conceptualized that we had to be thinking about what would this actually look when you take away me and you take away my colleague who's the clinical nurse specialist leading the mentorship and the clinical implementation of these pieces. Like, what does it look like once the funding dries up and the rubber hits the road? So what that required us to do was to be really critical about our own landscape from the get-go of, okay, we don't necessarily have the resources to add something new to the EMR. What does our EMR have in it? And how can we note and track and evaluate when people are engaging with this thing that otherwise had a 0% open rate? So the question around, this is me for the EMR in our intake procedure, it was thinking about things like that and getting creative, looking under the kind of nooks and crannies of what we have and asking people, okay, so you have a short 15-minute intake interview with this person. You want them to feel like a person and not a checklist. Start with a question like this. Open the door with what's important, what would you like your care team to know about you? And then let them know that we might ask some questions about some things that are a bit sensitive, but that we can come back to this at any point. And then working within our documentation strategies to have it be something that's continued and uplifted. So I guess from us, it was reflect internally first of like, okay, what's our actual landscape? And let's be realistic about this in a way that doesn't require an addition of a new role or things like that, especially because we know the resource landscape is a tricky one these days. So working with what we got as opposed to adding too much net new, and then just bridging partnerships within the center, I would say one of the other impacts that I forgot to mention is that this has really elicited almost like a community of practice within the pilot center of all the people who in piecemeal ways were enacting these approaches in their work, but they didn't necessarily talk to each other. They don't necessarily have overlap in their day-to-day work, but we built the platform for a working group that's kind of helped in a lot of the co-design and implementation, and then the working of our evaluation and sustainment planning agendas, which I'm hoping as a change management aspiration is a part of the structure that's also going to enable this to last beyond the time that my role is funded for. So I think that's the piece. It's not just making them feel like you get a star for being a pilot participant. You get a star because you are a champion in this work and you are a critical part of the continued reflexive practice of moving in equity-oriented ways. Because the tricky part with equity is that it's not a stagnant thing. It's always going to be changing what equity means at the various regional centers. So it has to be an ongoing commitment to kind of carrying that torch. And people who crave this work are craving those spaces to come together and do that. So that is an advantage, I guess, as well.
Excellent. Great. Thank you very much for these words of wisdom about extending and continuing those relationships, so these concepts of equity-centered care remain and are present in the care system. So I want to thank both teams of presenters, research participation through Rural Lens by Jude Conradson and Julia Bickford, as well as embedding community voices into an equity-oriented model of care by Emily Lonsdale. It has been an inspiring virtual session, and the invitation is for whoever is here in Vancouver to join us for a networking lunch just after this session. Then we're going to have roundtables and fabulous closing keynote in this afternoon. So thank you very much for participants and for great questions and reflections, and let's continue learning together in Putting Patient First 2026. Thank you, everyone.